We are live, sir.
Thank you.
Hello, good morning, everybody.
Good morning.
Good morning.
I welcome you all to our centenary celebrations of Dr. Ramachandra. I'm very happy to have associated with this esteemed institution, which was founded by Dr. Ramachandra. We are celebrating centenary year of Dr. Ramachandra. I'm very happy to be at the helm of the affairs as a dean and director of this institution at such a impromptu, important time. The college was started by Dr. S. Ramachandra in 1958, and then it has grown leaps and bounds. Thousands of graduates and postgraduates have come out of this prestigious institution. I'm also an alumnus of this institution. I have done graduation and post-graduation from here. I'm very happy to welcome you all for this event. We'll have one of our alumnus, Dr. Dwaraknath, who will moderate this session of webinars. We have several webinars planned. Today's webinar will be moderated by D Dwaraknath, who is alumnus of our institution. He graduated in the year 1975 from our institution. He went on to do his post-graduation. Then he has worked in various dental institutions across the country as a faculty. I welcome you, sir. Thank you.
Thank you very much, Dr. Girish. And very good morning to all my GDCites. At the outset, I trust, pray God, that all of you and your family are keeping fine at these very testing times. It's indeed a great honor for me to participate in Dr. Ramachandra's centenary year celebrations of our college. I had a close association with him until he retired. There are many anecdotes which I can recollect. I mean, that itself will go for 1 or 2 hours. Such a great man he was. And indeed, it is 50 years since I joined or stepped first into Government Dental College. In 1970, I joined GDC. It's exactly 50 years now. And the status of dentistry then, it was totally different. We could never imagine, dentistry will grow and a dentist will become a major role, or he will have to don a major role in the healthcare system. And it's indeed a very good moment for us celebrating Dr. Ramachandra's 100 years. The webinars that have been planned very aptly, the role of dental surgeon in the modern healthcare system. And the first speaker will be Dr. Vishal Dang. He will be speaking on oral systemic link. In fact, if you have studied dentistry way back in 1891, it was Miller who first postulated that oral microorganisms have a greater role in the general health of the person. And in around 1910 or so, William Hunter came out with this focal sepsis theory. Unfortunately, all those got fizzled out because they were basically, they were premised on anecdotal evidence. But today we have enough evidence, and Dr. Vishal Dang will highlight on that. And somewhat similar topic will be later covered by Dr. Pradeep, who will be speaking on periodontal medicine. Just to introduce you briefly about Dr. Vishal, he is, of course, our alumnus. He did both BDS and MDS from Government Dental College. in oral medicine. He is the visiting professor of University of Detroit Mercy School of Dentistry, and he has trained many postgraduate students. He established the oral medicine department in college in Faridabad. He is a member of various boards and public service commissions, and he is also the immediate past president of the Indian Academy of Oral Medicine, and he is also involved in national pre-cancer this thing survey, and he has developed a software for that. And it's really a pleasure to welcome you, Dr. Vishal. Please go ahead. It is all yours.
Is my presentation visible?
No, not yet.
Your entire screen, sir.
Yeah. One second. Yeah, it's the entire screen. I think I'm good now.
Yes.
Okay. A very good morning and namaskar to all the attendees of this webinar. First of all, I thank Dr. Dwaraknath for the nice short introduction which he gave for me. And at the outset, I wish to also thank the Dean and Director, Dr. Girish for organizing this event, which of course is in the memory of Dr. S. Ramachandra, the founding principal of GDC Bangalore. And this institution has been a pillar of scientific research, a pillar of clinical treatment testimony, and our commitment to society as far as oral healthcare is concerned. I also wish to place on record my thanks to the chairman of the organizing team, Dr. K.S. Nagesh, Dr. Manjunath, and all others, the technical team who have made this possible and brought this together. So, coming to my subject today, it is to sort of establish or indicate how oral health and systemic health are correlated. Now, when I was a student, the concept was that the mouth is the mirror of the body. But things have changed now, and I'll just come to that shortly. But this picture which you see on your screen now is how I see the science, the art of dentistry, and where I see my branch, oral medicine and radiology, in this hierarchy of subjects. We are like a tree, and a tree is incomplete without any of its constituent parts. And on top of this tree is public health dentistry. Whatever we do today, whatever research is done today, has no value, no use, unless it is brought down to the community. And each one in the society is able to gain benefit from this research. So I see the branch of oral medicine and radiology as the thick trunk which connects oral pathology and other foundational subjects with all other specialties, and the newest one, odontology, which is also now recognized as another branch by the Dental Council as a separate subject in the UG curriculum. So what is the change? The paradigm shift from when I was a student to now is that the oral cavity is not just a mirror of the body, but it is actually a mirror for the body. And it epitomizes the interdependence oral and systemic health. And the focus of research has shifted from just identifying signs and symptoms, of systemic disease in the mouth. When we were students, we were so happy to see a case sometimes where we found something in the mouth which could help us to identify disease. But today, things have changed, and the oral biosphere and underlying medical conditions, there is a two-way connect. It's a bi-directional connect, and the mouth is not just a mirror of the body, but changes in the mouth can also influence non-oral sites quite distant from the mouth. So when we talk about oral health status, what do we look for? We have certain markers of the oral health status, whether it is the teeth or the functional masticatory teeth, or how they've been affected by disease, as in caries, or we see periodontal markers, that is the gums, periodontium, and other factors which influence periodontal health, that is dental plaque, dental calculus, or we see mucosal markers where we want to assess mucosal integrity in health, including the close examination of the tongue. Then we also keep in mind how our jaws are functioning in a dynamic relation, and of course, the critical role of saliva, which brings everything together, which connects everything in our mouth. So, when we talk about oral diseases and systemic disease, the connection is known between infections. In the past, we have studied how tuberculosis from the lungs can affect the mouth, or how syphilis from the body can be seen in the mouth, or vice versa. But when we talk about non-communicable diseases and conditions, we find that there are several common risk factors, and some of these are in the picture in front of you. They are connected with use of tobacco, alcohol, sugars, and so this connection is in both directions. That means the risk factors, they are also responsible for several non-communicable diseases, and these risk factors also are responsible for diseases of the mouth, which includes periodontal disease, dental caries, and of course, oral cancer. Now, this nice picture, which I picked up from the biomedical, gives quite a clear depiction of how the mouth can cause disease, or I should say the changes in the mouth can produce diseases elsewhere in the body, such as cardiovascular disease, or diabetes, or it could be neurodegenerative disease, Alzheimer's, it could be, gastric disease, it could be respiratory disease, or even adverse pregnancy outcomes. And from this picture, if you notice, what is sort of common? There are lots of bacteria involved in these processes. That means there is, enough research today which indicates that bacteria from the oral cavity, if not causing a systemic disease, have a close association to cardiovascular disease. And perhaps this connection is also best researched in diabetes, and it is clearly established that in diabetics, oral health not just manifests or mirrors the systemic health, but in fact, a poor periodontal status is also a marker for metabolic deregulation in diabetics and a poor glycemic control. So all these bacteria which we see here are common bacteria found in the oral cavity, and the home, the nidus for all this is of course the periodontium. But after all, the periodontium also, and the teeth and the tongue and the mucous membrane, they are connected with the other structures in the oral cavity by the saliva. So the common medium is saliva, and the blueprint of all these bacteria is present in the saliva. So there are as many as 500 to 700 taxa in the saliva and dental plaque, the lining epithelium, and many species, most researched being Porphyromonas gingivalis and these Actinobacillus actinomycetum comitans species, which have been associated with non-oral systemic disease. And Fusobacterium nucleatum has been related to adverse pregnancy outcomes. Now, the point is that having established the cause and effect in many cases, I would say at this moment, we are at the juncture where the subsequent research is going to clearly indicate how these organisms not just are associated with systemic disease, but either are responsible for causing the disease or for progression of the disease. And these bacteria can easily migrate their toxins, the inflammatory products, they can migrate to distant sites and be responsible for systemic disease. So salivary biomarkers may be the diagnostic tool of the future in predicting systemic disease. But let's put this in perspective. Should we wait for the salivary biomarkers to be brought into clinical practice? Is that the way to go for a country such as India, where the population of 35 crores has so much of caries, periodontal disease, and basic oral hygiene practices are not practiced? So I think we should not wait for this sort of a research before we act. The time to act is now. See, I already mentioned that many conditions, some of these are listed here, and their association has been established by the FDI, by the Cochrane Oral Health Group, by various well-recognized and respected research bodies. And this connection is a very, very strong connection, although the cause and effect has yet to be proven in most of these cases. So the jury is out. It's just a matter of time. Now, as far as COVID-19 and oral health is concerned, this virus, this RNA virus, is neurotropic and mucotropic, and it affects the oral mucosa. We have read that it affects the taste and the smell and salivary gland function. So that means this virus is going to affect the health of the oral cavity. Conversely, if we see the other way around, that the bacterial load and inflammation and hyposalivation, which is caused by so many medications, such as cholinergic medications, the antihypertensives, NSAIDs, these also increase the COVID-19 risk in the person. So COVID-19 has also been shown to cause changes in the oral cavity, ulcerative changes. But the point is that we should see the bigger picture, and here it can be in both directions. So current research, epidemiological, clinical, experimental, indicates that bacteria, bacterial toxins, and inflammatory products of origin may play a significant role in the onset and or progression of certain non-oral systemic diseases. So what is the evidence? What is the evidence? Diabetes and periodontal health. Diabetes has a direct impact on periodontal health. The evidence for this is very high. And as dentists, we have all been aware of this. Now, periodontal disease may affect development of type 2 diabetes mellitus. The evidence of this is uncertain, but as I mentioned that if the oral health is poor, usually the glycemic control of the person also is not very good. And there is also moderate evidence to indicate that the progression of disease may be dependent on the oral health. Now, a lot of research has gone into cardiovascular disease, and there is a strong association. It is an association, mind you, not a cause and effect relation. This association has been established between cardiovascular disease and oral disease, especially periodontal disease. Now, here there is a risk factor commonality. That means the risk factors for oral disease, such as we talk about, the diet, we talk about tobacco, we talk about so many other common factors, risk factors. These are common between cardiovascular disease and oral health, especially periodontal disease. And of course, in cancer, there is some evidence that there is an association between advanced periodontitis and cancer of the rectum, colon, lung, and even oral cancer. There are researches to show that the sickness of the cancer cells is more in the presence of periodontal infection. And of course, there is a special age group, the older population, where the oral health and systemic health is so critical, especially in terms of respiratory diseases and in terms of malnutrition. So oral health, of course, is going to affect systemic health in this group of patients and other patients who are immunocompromised or at the extremes of the age groups. So what about death? What about mortality? Is there a connection between oral health and mortality? Now, it is very difficult to establish a research model and how to study this association between death, mortality, and oral health. Of course, there is some indication that all-cause mortality and dental plaque, gingival inflammation, and number of teeth in the mouth, if there are more than 10 teeth missing or less than 5 masticatory units, they can impact mortality in populations. And cancer mortality and gingival inflammation, dental have shown a positive correlation with each other. That means that if you improve the periodontal status, probably cancer mortality can be brought down. Now, if we talk about tobacco use, the GATS-2 survey of 2016-17 shows that as many as 28.6% of all adults use tobacco in some form in India. That means there is a shift from smokers to the use of smokeless tobacco. And there's a big percentage which practice both these forms of habits, which put the population at the risk for oral cancer. Now, oral cancer is not a disease of the mouth alone. Oral cancer is very much a disease of the entire body, and it should be viewed with that perspective. We, of course, know that tobacco has so many, effects which impact systemic health, which are now on the picture before you. Whether it is cardiovascular disease, whether it is hypertension, atherosclerosis, name it, bronchitis, emphysema, cancer, and Alzheimer's, infant mortality, etc., etc. So there is no doubt that tobacco is perhaps one very big single causative factor or risk factor which connects oral and systemic disease. So what about the Indian scenario? So far, dentistry has taken an approach where treatment has been more important than prevention. In the Western world, for example, even in Europe today, the amount of funding which goes into dental treatment is perhaps just third after diabetes and cardiovascular disease. Now, for India, where 5.8 million deaths per year, 5.8 million deaths per year are on account of non-communicable diseases, and 60% of all deaths perhaps are because of the NCDs. The WHO is projecting that by 2030, cardiovascular disease is going to be the single largest killer in India. Now, should we wait for that pandemic to hit our population before we take this forward and put this, proposal with the healthcare providers, put our research before the medical fraternity, because we know that periodontal disease prevalence in India varies as high as 95%, and even caries prevalence is very, very high. The oral cancer incidence is also one of the highest in the world. Oral cancer is one of the commonest cancers in men in India and third most in women. And so it is important that we need to now change our approach from treat to a prevent over treat approach, and we need to address these issues now for improving the oral health, which in turn can improve systemic health. So in conclusion, it's just my take that proper oral care, including the management of periodontal disease and addressing all the risk factors, will have a positive impact on morbidity, mortality, and the economic burden associated with non-oral systemic diseases. I wish to emphatically suggest that systemic health targets for the population cannot be achieved. They just cannot be achieved without addressing oral health needs at the community level. So, just a brief presentation from my side. There is no doubt that today we are standing at crossroads where the oral health is impacting systemic health. And this connection is not just in one direction, but is in both directions. And this is what needs to be brought into the academic institutions for teaching the undergraduates and the postgraduates. And this is what needs to be emphasized with the other medical professionals and which brought into picture when we discuss with the government and the healthcare providers and funding for this. So you can't have a healthy nation without a healthy mouth. Thank you.
Thank you very much, Dr. Vishal. You have touched upon various aspects in a very concise manner. One question I have is that you are involved with pre-cancer research, and you also mentioned about saliva as a biomarker. Is there anything that is in the offing wherein saliva could be, or any biomarkers have been found in the saliva which perhaps leads towards developing malignant condition?
Sir, the first thing in malignancy is that it is a multi-step process and no single biomarker is at the moment, offering a solution to us. So it's actually a cocktail of biomarkers. And even till date, even if we go by the WHO's, understanding that the conventional oral examination by an oral expert is still the best method today for early diagnosis of cancer, and mouth self-examination also has a role. But I think before the biomarker, issue comes into practice, there is still some time, and I don't think even when it comes in, it would be very practical for a country like ours where costs and availability of resources and infrastructure would be a constraint.
And my second question is, of course, it's a very short time to have seen COVID-19. Apart from the loss of smell and taste, we have had one or two reports of patients losing their teeth spontaneously. It must be some sort of osteomyelitis, I believe. But is there anything that you have learned, where there will be clear oral manifestations of COVID-19?
Yes, so that's a nice example which you quoted about loss of teeth and sudden loss of teeth. But these are very few and wide apart sort of these such reports. And when I view the whole picture, I don't think that COVID-19 has any special impact on oral structures, which is much different from other viral infections. And so in that sense, we perhaps need to be as careful with COVID-19 as we are with any other infection. And of course, cross-infection and transmission of infection being the biggest challenge, I think.
Yeah. Thank you very much, Dr. Vishal. And that was a very good presentation. Now we go to
Thank you, sir.
Our next presenter. Now, one thing I always believe, if there is one branch in dentistry which can give a run for its money to all the general surgeons and physicians, it is oral and maxillofacial surgery. And we have had many good oral maxillofacial surgeons. I mean, The time when I went in, entered BDS, it was sort of limited to removing of impacted teeth, road traffic accidents, and some cancer surgeries. Of course, we had very good surgeons like Dr. Dhanashekaran, Dr. Dudani, Dr. Jeenwala, and our own Dr. Raju. But today, our people like Dr. Girish Rao and Dr. Kittu Krishnamurthy, who are our own alumni, have taken this branch of oral maxillofacial surgery to great heights. Dr. Girish needs no introduction. He passed his BDS from our college with having stood first in all the 4 years and getting gold medal. Then through All India entrance examination, he pursued his MDS in oral maxillofacial in Tamil Nadu Government Dental College. After that, he obtained his FDS, RCS, both from England as well as Ireland. He worked in some British hospitals. Then he came back in 1999 to India. He worked as a professor and head of the Department of Oral Maxillofacial in RV Dental College for about 17 years. In every major hospital in Bangalore, he is a consultant. He is a very good speaker. I have been associated with him in several teachers training programs. And I remember both of us formed the syllabus for the certification of implantology course for the Rajiv Gandhi University. And it's a great pleasure to welcome Girish. It's all yours, Girish.
Very good morning, and thank you very much, Dr. Dwaraknath, sir, for those very kind words. It's such an honor to speak in the first webinar series on Dr. S. Ramachandra's centenary celebrations, which we are all celebrating this year. He was the founder principal of our esteemed institution, and under now the able leadership of Dr. Girish Gireddy, the Government Dental College is really running very high, and I'm sure this institution is going to be probably one of the best institutions in the world. I would also like to thank my own teacher and mentor, Dr. Nagesh, who is spearheading this centenary celebrations of Dr. Ramachandra, along with our dynamic Dr. Manjunath Puranik, who has made this possible. I would also like to thank Dr. Reena for giving us this platform to educate so many dental surgeons across the globe. Thank you, Dr. Reena, if you're watching from Delhi. It's such an honor that we are on your platform, which you have created in this made in India kind of concept. Let me share my screen, and I'll... Is my screen visible at all?
Yeah.
I can't see my screen.
Yes.
I need to go into application. Oh, where's my screen? Can I just minimize this? Just 1 second. There's some technical glitch. Can you come in?
In the application window, sir, you have to select the PowerPoint.
Yeah, 1 second. On the application window.
Your entire screen.
I got into the entire screen.
Yeah, select that. Select. Yeah, now share. No, yeah, no, shared it now.
I need to get into my screen. 1 second.
Your screen.
Entire screen.
Your entire screen, you shared it. Now select that. Select.
There should be one more screen on there.
Okay.
Go into my inbox. I'll get me. Where's my PPT? Close this up. Close this up. I think I have some technical issues in sharing my screen.
Your entire screen and then just click the share button.
Share the screen. But where's the PPT?
But my PPT is not seen on that.
You have to open your PPT then if you're sharing your entire screen.
Let's minimize this. I'm not going to try it. 1 second. Can we minimize this?
Yeah.
Go to my PPT. Where's my PPT? My PPT is there.
Are you able to see it here?
Yes, now share your entire screen.
Can you see it?
I share it, no? Why are you wait?
So, Dr.
Yeah.
Dwaraknath, sir,
Can they see
why
it?
don't you go for a next
Yes, please.
projector? Next letter by the time Dr. Girish can etc. It is the problem.
Just 1 second. Application. Yeah, I think I've got it.
Okay, right.
No.
Yeah, we have got it.
Yeah, can you see me?
Yes, yes.
Is my yeah. I'm sorry about this technical glitch. Well, I've been asked to speak on this very interesting topic on oral and maxillofacial surgery and interdisciplinary approach. I think surgery has evolved considerably from the last century. This is how surgery was so barbaric. And when it comes down to oral and maxillofacial surgery, when I was training back 30 years back, most of the surgeries, like what Dr. Dwaraknath said, was very, very minor surgical procedures. It was extractions, impactions, alveoloplasties, and if it was trauma, it was just intermaxillary fixation. If it was TMJ surgeries, we would just do a release of the ankylosis with a gap arthroplasty, or at the most swinging the temporalis muscle and what's called as the interpositional arthroplasty. And when it came down to cysts or tumors, it was basically resection of the tumors or enucleation of the cysts and packing. There has been a huge paradigm shift in the way in which things have been practiced today, thanks to our great teachers, Dr. C.G. Raju, Dr. R.M. Hebberly, who was my professor when I was in GDC, and then Dr. J.P. Shetty, and a number of other teachers who has given me this kind of training. And of course, later on, leaders in India itself, like Dr. Kishore Naik, Dr. Krishnamurthy Bunantaya, who are also alumni from our college, have made a huge change to transform our maxillofacial surgery. And today it is craniomaxillofacial surgery. This has, basically we are today dealing with a number of other surgical procedures, starting from cleft lip and palate to facial deformities, which could be treatment of orthognathic surgeries for facial deformities, oral oncology and reconstruction using microvascular surgeries, which a lot of maxillofacial surgeons are now doing today. Skull-based surgeries and craniofacial surgeries in conjunction with neurosurgeons, TMJ total replacements for ankylosis, salivary gland pathology, where we actually preserve the nerves and get them patients back into their normal function. And of course, a lot of aesthetic facial surgery, which could involve a rhinoplasty or a facelift or a blepharoplasty, and a simple dental implants or facial implants for maxillofacial prosthesis. So this has completely revolutionized in the last 30 years, I would say, the way in which our surgical specialty has changed. A lot of factors have contributed to that. And one of them is probably the interdisciplinary approach. The kind of knowledge which we have acquired from different other specialties into our own specialty has made a huge transformation. A new paradigm has been created. And from a very, very barbaric surgery, today we are able to do an extremely pleasant surgical procedure and get fantastic results with this kind of approach. And this interdisciplinary approach is probably the key for our success, I would say, in addition to the transformation which has happened in the basic surgical approach itself. Let me take this presentation through a few cases where we see this multidisciplinary and interdisciplinary approach. A simple cyst in the jaw, I think a number of specialties today are coming in today. We have the oral medicine and radiology coming in with diagnosis and doing very, very fine CT scans. It could be a CBCT, which gives us so much of information to identify and localize even where the nerve traverses through. In a small kid, we have a periodontist and an orthodontist taking care of the occlusion, and a prosthodontist comes in to basically rehabilitate that bone with the implants which a surgeon has put in by putting a crown and doing a complete rehabilitation. And of course, our oral pathologists give their final verdict as to what the pathology is. To showcase some of these cases, let me show you this young boy who had a large cyst in the mandible. You can see the kind of a lesion in the mandible with the baby teeth still in place. And that is where we have enucleated the entire cyst, removed it completely. And in this case, we used what is called as hyperbaric oxygen therapy for accelerated bone healing. In fact, one of my postgraduates did a thesis on that to see how early we could regenerate bone. And that's where within about 6 months, we were able to get the entire bone completely healed. Of course, it's a pediatric age group. We know that it heals very rapidly, but in giving hyperbaric oxygen, that means that giving oxygen at 2.4 atmospheric pressures, basically you are actually increasing the growth and the healing process. So here we had the bone completely formed, and we started noticing that the supraeruption of the teeth would happen. And that's the reason why we gave him a partial denture. But kids being kids, they do not wear these kind of removable appliances. And we had issues. So there were issues with supraeruption, which we were very much worried of the opposing arch. And that's where my first case of pediatric implants, which I did in a beautifully regenerated bone in a cyst. And this guy was only about 10 or 11 when we placed his implants and 3 implants there into a regenerated bone. And you can see the way in which we have been able to rehabilitate as a multidisciplinary approach, a surgeon and a prosthodontist coming together, and we have solved the problem of supraeruption of the opposing arches. So from here, where you could see a large cyst in a pediatric age group, we have completely rehabilitated. Of course, we have given a temporary prosthesis. As the kid grows, we can actually replace it with a zirconia prosthesis. Not only with dental specialties, we interact very closely. In trauma, it's basically a multidisciplinary approach again. There we have the accident and emergency physician who receives the patient immediately. Today, maxillofacial surgeons are called for both hard tissue and soft tissue trauma. The neurosurgeon comes in if there is a head injury. And of course, if other bone injuries are there, orthopedic surgeons come in. And then if you are taking the patient for surgery, you have the anesthetist. And of course, in the post-op care, in the critical period, immediate post-op, you have the intensivist who takes care of the patient in the ICUs. So we have been very, very actively involved in all facial traumas today. A simple case could be a mandibular fracture like this, or it could be a more complicated trauma, a blowout fracture like this here, where you can see the orbit has been completely devastated. Or even this is a 3D reconstruction where the entire facial skeleton has been very, very badly fractured. A simple case to demonstrate this, you can see the kind of trauma where the zygoma and the maxilla has been completely shattered. Through the existing laceration, we have actually approached it. And using today these very, very fine, low-profile plates, we've been able to reconstruct this face completely. And we have given a beautiful face, which is almost normal, other than the fine scar, which is over there. Orthognathic surgery is where, again, there is a multidisciplinary approach between the orthodontist, maxillofacial surgeon, and the oral medicine and radiologist. A case to demonstrate this, you have a young lady who has a very, very significant prognathic mandible. This is where she has a class 3 kind of occlusion. We start off with pre-surgical orthodontics. That is where my orthodontic team comes in. And we basically align the arches, level the arches, and correct the crowding. And then we subject the patient for a simple surgical procedure. Again, done from inside the mouth, so you're absolutely not having any scar. The mandible is split in the ramus region in the sagittal plane so that the inferior alveolar nerve can be completely teased out without damaging it. That's the split which we are doing in the ramus of the mandible. And you can see here, this is the canal and the nerve is completely intact. And once you have the split correct, then you can move the mandible either forward or backward. In prognathism, we take the mandible back, fix it with tiny plates and screws. So you can see the way in which in the lateral cephalogram, the mandible has now completely repositioned into a class 1 kind of position, fixed with tiny plates, and the patients do not even need intermaxillary fixation. They start functioning from day 1. That's the kind of results which you can give to the patient. The entire profile changes, the occlusion completely transforms, and not only we are able to give a functional and an aesthetic result, but you're able to change the psyche of this patient, and they become a much more positive, extrovert kind of patients. And that transformation is possible if we bring in value from different specialties. In this case, it is an orthodontist, a maxillofacial surgeon, and an oral medicine and radiologist who gives us that beautiful information in the CT where the nerve can be really protected. Moving on in other pathologies and reconstruction, again, we have a multidisciplinary approach. This is a young man who was a software engineer from US. He came the moment he was diagnosed with an amyloblastoma. He came back from California to Bangalore, and he had a huge amyloblastoma. You can see the ramus of the mandible involved over here, and he had to be subjected for a hemimandibulectomy. That's the CT 3D reconstruction. You can see the kind of perforation of the lingual cortical plate. That's the amyloblastoma which has been exposed through surgical approach. And that's the mandible which has been resected. You can see the condyle is intact. And this is the huge amyloblastoma which you can see, which is involving the mandible. Now, reconstruction today, we are basically taking fibula. This is basically the leg, the second bone. The tibia is the weight-bearing bone, and fibula is the non-weight-bearing bone. And this is the leg, what you're saying here, and that's the pedicle. So you have the artery and the vein, the peroneal artery and the vein, which basically perfuses this tibia bone. So we osteotomize it. That means that we make the cuts. A straight bone is made into an L-shaped bone to mimic the mandible, which we have resected. We've taken the condyle and put it back here. This is in the leg itself, what we do. And in the leg itself, we are putting implants. So here you can place the implants in, and you can put a temporary abutment like this, and you can actually do a prosthesis straight away. So you can do an immediate loading because fibula is a very, very hard bone. So you basically shift from the leg into the mandible where we have resected and anastomose the artery, the peroneal artery into the facial artery, and the peroneal vein into the internal jugular vein, so that this becomes a viable bone graft. That means that it is alive from day 1. And that's the post-op X-ray. You can see the fibula has been osteotomized to give that L-shape. The same patient's condyle has been put in here. You can also put a condylar prosthesis too, but if the condyle is not involved, you can use this. This is called as auto-transplantation of the condyle, and you can load these things directly, and that is how we can contour the patient immediately after surgery. This is in about a month's time, and that's the dentition which has been replaced. So not only we are resecting the jaw, reconstructing it, but we are rehabilitating this patient, giving implants. And that's where a multidisciplinary approach, a reconstruction surgeon, a maxillofacial surgeon, a prosthodontist who comes in to give the crowns, that is how we are able to get this kind of results. Today, we have taken this one step further, bringing in a software engineer into position. I mean, it's not just into medical fields we have now moved on. We now are interacting very, very closely with radiologists and software engineers where you can do virtual surgeries. And that is where I'm going to show you a case where we have a multidisciplinary approach. A young lady who didn't want a fibula, and this was one of the first cases where we have done a 3D printed mandible using titanium or PEEK you can use today with implants. So this lady had a amyloblastoma, you can see here in the mandible. So she had to undergo a resection. That's the 3D model which we have done, and the planning is done virtually. And that's the prosthesis which we have done beforehand itself. So it's an exact measurement. In fact, we get cutting guides so that you know precisely where to cut. So I'll be showing you how we do that. And that's the kind of surgery which we do. And this is the prosthesis which goes in there. These are the cutting guides. So you actually fix the cutting guides. You actually plate it or screw it in position. So it's very precise. make your cuts using a saw there, and then you take out exactly a predetermined position, giving good margins. You can see here a margin, a centimeter margin is given all along, and then immediately you fix the prosthesis with the crowns in place. So you've got this patient now who essentially has a beautiful contour, and into these implants which are jetting out through the prosthesis, into which you can fix crowns there. And that has made our life so much easier. And that's the kind of OPG which shows the 3D. This is the latest technology which we are using this multidisciplinary approach. And that's the kind of results which you can give to your patients. So it's amazing the way in which when we bring in value from different specialties, it can actually make a huge difference to our patients. And we can really do cutting edge technology, cutting edge surgeries to your patients. I'm going to show you one last case where we collaborate very closely with the neurosurgeons, and that's where maxillofacial surgeons today are interacting in the medical professions too. This is a case of a frontonasal encephalocele. This is like a hernia. In hernia, it's an abdominal hernia where it comes through the defect there, and here you have a defect in the anterior cranial fossa. So what has happened is the frontal lobe herniates through the defect in the anterior cranial fossa, and you can see the wide eyes. That's called as hypertelorism. Both the eyes have splayed apart. So we have planned to resect this frontonasal encephalocele and also correct the position of the eye, and that's called as hypertelorism correction. And that's where, as maxillofacial surgeons, and that's where we call ourselves today as craniomaxillofacial surgeons, we are interacting very closely. In fact, I've been working at NIMANS for the last almost 17 years and probably done hundreds of cases over there of these kind of cases, which are very challenging, where we work very closely with the neurosurgeons. That's the defect you can see here through the anterior cranial fossa. And you can peel the scalp down. That's the bicoronal flap which we have raised from the top. That's the eye being mobilized completely. This is the eye socket which we osteotomize. So we use a regular straight fissure burrs, or you can use a very fine saw, but because there's a child, I like to use a very fine drill. And you can make a beautiful spectacle osteotomy. That means that the orbits are osteotomized completely. You make your cuts. The eyeballs are mobilized completely 360 degrees. It is just hinged on from the orbital apex. The optic nerve is basically the structure with the cone there, which is protecting it. And this is the complete eye socket, which you can mobilize. The central excess bone is basically taken out in the middle, and you basically bring the medial walls of the orbit together, and you osteotomize it and bring it together, and you correct the defect over here with a small bone graft which is taken from the inner cortical plate. And that is something which we do it, and we bring these two orbital osteotomy cuts which we have made together and fix it to the frontal bone there. And you can use resorbable plates, which I've used in many cases, but in this case where economy matters a lot, we have used just simple stainless steel wires to bring it together, and then we have brought the whole thing together. And this is the post-op results where the eye has been brought together, and that's the transformation which you can do. So from here, we've got him like that, and from this kind of scenario, this is the kind of results which you can get. And that is very important in terms of collaboration. So if this gentleman can do it, I think we as dentists from Government Dental College, Bangalore, who have been trained so beautifully from our mother institution, can really do wonderful jobs, provided we work together. And team approach is probably the key for our success. Team stands for together, everyone achieves more. Thank you so much.
Thank you very much, Girish. As usual, very precise, lucid, and the cases which you showed are simply awesome. You are indeed a proud son of our TDC Bangalore alma mater. Just one question to me, seeing the type of cases, the extent to which the growth of our oral maxillofacial surgery, in fact, you say it is cranio-oral maxillofacial surgery. Do you think there is a case for an MCH in this specialty?
Absolutely, sir. I think the key is basically further training. And I think we have had, the ceiling of only an MDS program. But in the surgical specialties, they have moved on and are having definitely a higher training, which is an MCH. We have actually introduced fellowship programs. And I think the Dental Council of India and other apex bodies are seriously looking at it. There has actually a precedence in this. All India Institute of Medical Science of Raipur, they have actually, I think it's in Rishikesh, they have actually started an MCH program in craniomaxillofacial surgery. So I think there is a huge need for a program like this. And I'm sure, our good friends like Dr. Janakraj Sabharwal, who are also the key maxillofacial surgeons in Delhi, I'm sure he will be pushing this to make it better so that we train our own youngsters to take our specialty in a very, very well-trained, very well-structured program so that our patients can get the best benefit of it. Thank you.
And your honest opinion about the need for an MBBS degree to practice oral maxillofacial surgery.
Sir, I feel there is absolutely need for that. I think if you are trained, doubly qualified like what is in UK, the range of work which you can do is very, very huge. I personally feel that if you are practicing oral oncology and reconstruction or craniofacial surgery or cleft lip and palate, there is a need because you are handling so much of medical problems on the patients on whom you are operating. So I think there is a definite need for people who are interested in doing higher work. I think we should be definitely looking at training a sect of our maxillofacial surgeons to do double qualification. There is definitely. But if you're doing simple routine oral surgery, a wisdom tooth or an implant or simple trauma cases, simple alveoloplasties and minor surgical work, I think an MDS is good enough. But when you are extending beyond what you're actually going in, I think that's where you need higher training. So an MBBS and an MCH and further training is probably definitely a need of the hour. And I was lucky that I went to UK and I learned as a senior house officer, the biggest training which they gave us was basically a fundamental surgical training. Patient management was the key. Looking at the patient from the medical perspective was probably more important than just doing surgery. Surgery is a guild. But if you have a medical degree, then you can identify a problem much earlier and you can be a better surgeon. So personally, I definitely think there is a huge need for MBBS program also, which can be brought into the curriculum. So if we are having a 3-year, like I like the US program because they incorporate an MD, which is an MBBS program during their training in maxillofacial. So it's a 7-year program where you do 3 years of medicine, surgery and 4 years of maxillofacial. Something like that, a bridge program like that can be a big benefit to India.
Yeah, good, Girish. Just on the lighter side, you can do so many wonderful surgeries. I think the implant you should leave us poor periodontists like us. Yeah. Yeah.
Thank you.
Yeah. Coming to periodontics, we have our next speaker, Dr. A.R. Pradeep. He has the rare distinction of doing BDS, MDS in the same college, then becoming a teacher there, a professor, head of the department, principal, everything in his alma mater. And as far as Pradeep's biodata runs into 40 pages, I mean, it takes a whole hour to read that. But if I can put it in one sentence, periodontal research, when it is concerned, Pradeep has put GDC Bangalore on the world map. It is so much recognition he has, and through him, our alma mater has got the recognition. Okay, I'm not going to give you statistics of what is his Google citations, how many articles he has published, but simply putting that he is the one guy who has been recognized all over. So he is going to enlighten us on periodontal medicine. Now, as you know, already Vishal has brushed upon this subject. There is a strong correlation between periodontal status and many systemic diseases. Unfortunately, I feel sometimes we carried this too far. So many diseases were connected with perio, and perhaps because of that, it lost some steam. But then still, it is very, very important. And Pradeep is going to highlight on some of the vital aspects of this. It's all yours, Pradeep. Welcome.
Thank you so much, sir, for a nice introduction. Good morning, good afternoon, good evening, friends across the globe. It is indeed a great opportunity for me to celebrate this centenary birth celebration of our founder, principal, Dr.S. Ramachandra. Today, whatever we are, it is because of him. He has done the college extensive today. I thank GDC alumni as well as my GDC people for giving me opportunity to share today webinar along with Dr. Girish and Dr. Dang and Dr. Sahana and Dr.ShivaKumar. And also, I thank Professor Nagesh for giving me opportunity. Also, very thank all my teachers here on the team who were sharing this. Dr. Mohammed Faizuri, Dr. Dwaraknath, Dr. Jayapal Shetty, Dr. Iremad, Dr. B.K. Venkataman, sir, all my teachers. Today, what I am here, it is because of this. Even where I thank my GDC alumni today, where I married my wife. She was my student and she became a girlfriend and student and my wife today. Thank you for GDC. I salute GDC. I share my screen now. We'll go ahead with the presentation. Good morning, good afternoon, good evening again. This my webinar series goes for Dr. Ramachandra birth centenary celebration today. This December 18th, we're going to celebrate. My topic of the warm greetings from me. This is my alma mater, where I come from, and where I finished all my first innings here after 42 years, being a BDS student as well as MDS. As a faculty, I retired in the month of April 2018, where I joined to the Oxford group of institutions. Right now, I am doing second innings at Oxford Dental College as a dean and director and professor of pedontology. My topic of a presentation is on periodontal medicine. Periodontal medicine is the new discipline that is introduced in the field of medicine to validate the biological plausibility between oral diseases, in particular periodontitis, and systemic health in these more susceptible individuals. The terminology was coined by Offenbecker in the year 1996. But, however, when you go back to the history of this periodontal medicine and the focal infection and throughout the history of the mankind, they must believe that the disease which affect the mouth, particularly periodontal disease, can affect the systemic health also, as well as the rest of the body. Over the centuries, from the ancients, speaking from Greeks, Romans, Aryans, and Hebrews, they all had a concept saying that oral health will affect systemic health. At this juncture, I want to name the two persons who have worked extensively in the year 1891. Professor William Hunter, who was a physician in London, and W.D. Miller, who was a microbiologist, who has worked in Robert Koch along with him in the Berlin University, and he himself was an instructor in the microbiology department. These two persons were brought into the picture. They were trained there, and they brought up in 1891 on oral infection related to periodontal disease and towards systemic health. And in the year 1891, William Hunter left back to the Montreal and he delivered a lecture on McGill University. He has attracted many of the audience over there with the researchers and the scholars. They have attracted, they were saying that his periodontal disease has got a systemic link. And later in the year 1912, Professor Frank Billings, he coined the terminology as periodontal as focal infection, and later by periodontal medicine by Offenbecker in the year 1996. I'll just go ahead with the presentation. Today we have got a linking, as Dr. Vishal said, about 54, but I say it's 85. A to Z. A stands for Alzheimer and Z stands for Zika. There's so many linking has taken place. So many reviews has been done. So many systemic research has been done. I see at the juncture only one which has put as a causal relationship is on diabetes is a two-directional relationship or called a bidirectional relationship. Even I go to the extent of saying with the systematic reviews, even cardiovascular diseases also I got a systemic link and they are found. And even I say obesity, rheumatoid arthritis, and adverse pregnancy outcome. These are the 5 things I can say with the systemic. They have the link with periodontitis. Periodontitis plays a key role because it's inflammatory and dysbiotic disease, and it's a complex disease which has got multiple genetic polymorphisms as well as the multiple environmental risk factors. Complex disease. There are 3 complex diseases in human diseases. One is periodontitis, second is Crohn's disease, and third is rheumatoid arthritis. There are 3 considered as a complex disease where we fail even today to treat these 3 diseases. Periodontitis, as I show in the figure here, it is linked with so many diseases, starting from head to toe. It affects the brain. It causes several vascular accidents, or it causes Alzheimer's, or it may cause Parkinsonism. As then that may involve even with the heart, causing atherosclerotic valvular diseases, or that may affect the lungs, causing COPD, chronic obstructive pulmonary diseases, or that may affect the pancreas, causing diabetes, or maybe go to the joints, rheumatoid arthritis or osteoporosis, as it may cause even for adverse pregnancy outcomes. So this, I'll go ahead with my presentation with this brief introduction. Oral health is the mirror view of the system health, as Dr. Vishal has said. This is a doorstep for to be a healthy and fit. Because I say because this point is same blood flows throughout the body, as Jeff Court has stated that in his statement that the same blood flows throughout the body. Whatever the disease happening in periodontal pockets, it's gram-negative anaerobic rods and cocci, which secretes the lipopolysaccharides and endotoxins. And this has a perpetuation and on the host cells, which can liberate the cytokine. That's called a pro-inflammatory cytokine in the form of interleukin-1 beta, interleukin-6, 10, TNF-alpha, 17, 18, and so forth. They are the one which cause cytokine storm, like what you see in COVID-19. Same thing applies here too. They are all entered the bloodstream and causes all the systemic health diseases. Now, the focal infection theory, now it is recoined by Periodontal Medicine, as I said earlier, but some of the authors at the late on the 1940s, where they didn't believe because once you remove the tooth, they didn't find any improvement in systemic health, or absence of teeth, or with the patient with disease-free mouth, they didn't find any improvement in systemic health. This concept that was gone for the last 40, 50 years. Later in the year 2000, Orelli and Clavini, 2000, they brought about the literature into research and found this was eye-opening for all research. The explosion of the research has occurred in the field of medicine, dentistry, nursing, and pharmacy. There is some amount of correlation between periodontitis and systemic disease. Today, the explosion of research on this field is extensive. Even American Journal of Cardiology and American Academy of Periodontology in the year 2009, they brought up the consensus of periodontitis and atherosclerotic cardiovascular diseases. They have stated that inflammation may be one of the mechanistic link between these 2 diseases. See how the periodontal disease involves the periodontium is a normal healthy periodontium because of the plaque is a subgingival biofilm. Is about, as he said, Dr. Vishal, about 600 to 800 species. They are not only gram-negative, we can say mythogenic group of bacteria, L form of bacteria, viruses. Still more, we are not understand exactly the pathobiology and pathophysiology of periodontal disease. At least now we understood why it is called dysbiotic inflammatory disease, and which has got the sheer risk factors and releases all the cytokines. See how the periodontal health will be there. And because these are the normal common sources in the orchid, there will be symbiosis. Then in case of little inflammation called gingivitis form, it can reversible. If it is not treated well, this condition of symbiosis will transform into the dysbiosis. It induces the gram-negative anaerobic and causes a dysregulation in the inflammatory response, and they enter to systemic circulation and brings about all the systemic changes in the distant organs. See, this is how it happens. See how the biofilm subgingival area again causes systemic bacterial dissemination and promotes atherosclerotic plaque in the cardiac vessels. They have noticed that they have taken a plaque from atheromatous plaque, and with subgingival biofilm, they have noticed gingivalis over there. That's how there's a link that was established between periodontal disease and cardiovascular diseases. But still, we have to do a lot of systematic reviews and interventional works has to be done to say, no, it is only whereas it's causal relationship, not a causal relationship. Again, how we can affect acute phase protein, HCRP, or the superfamily of acute phase protein, I say pentraxin 3, which also play a key role in the kidney dysfunction syndrome. See how the systemic inflammation, they enters by all the pro-inflammatory cytokine, interleukin 1, beta 6, 10, and TNF-alpha, and so forth. TNF-alpha is always referred as suicidal hormone in pregnancy. That's how it brings up the adverse. And as Dr. Vishal said, even dysbiosis will be there, it affects the gut also. Inflammatory guts brings up inflammatory bowel disease and the Crohn's disease too. And finally, it adverse pregnancy outcomes in the form of preterm birth or low birth weight children or early pregnancy loss or other eclampsia. So there will be rupture of membrane earliest because of TNF-alpha and other pro-inflammatory. That is why I said that oral health is very important, and in particular periodontitis. We have to go at the level of the rural people as well as our medical people, and to say that how important is on systemic health. Even recently, ISP, Indian Society of Periodontology, with the diabetic groups of India, we conducted all the research works on this and published a paper with a joint consensus report that is published in November 2020. See now how the periodontal tissues, the bacteria, right? They enter the viral bacteria, lipopolysaccharide and endotoxins, and they work on the cells of human cells like the lymphocytes, monocytes, endothelial cells. They have their own cells. Perpetuation of these lipopolysaccharide, they bring about release of all the cytokines, and which will have an effect on systemic tissues, either with the heart, atherosclerosis, or is the Alzheimer's disease, where the beta amyloid ratio is happening. Even I have done publication, I have published in the American Journal of Dementia, and that will have even in the stroke too, cerebrovascular stroke, or bring obesity, or rheumatoid arthritis, or we can have COPD in the lungs, and so forth. And diabetes, more important, I say for everybody. India is going to be the capital city of diabetes by 2030. We have to go at the levels of the rural population, and we have to tell the patients as well as the doctor how important the oral health and plays a key role in the diabetes, as well as for the gynecologists to say what are the pregnancy outcome will be there. We have to instead gynecologists too regarding the importance of periodontal health and oral health on the adverse pregnancy outcomes. This is how the Bradford, whenever we do any reviews or any systematic work has to be done, we should fulfill the Bradford criteria. 9 criteria: temporality, plausibility, consistency of the thing, strength, dose response, specificity, reversibility, and coherence and analogy. These are the 9 Bradford Hill criteria should be put forth before we talk. This is the second set of pyramid. Today, the research we talk about. What is the research? We should have systematic reviews. They are the ones that is highest in the research guidelines. Coming to the periodontal disease and diabetes, this is the one disease which has got a causal relationship and bi-directional relationship and diabetes. Even I have also worked on these two fields. I published a lot of articles on diabetes and periodontal disease, and which published in journal Periodontology. See, diabetes and periodontal, how the same mechanism, defective host response from the diabetes causes hyperglycemia, hyperlipidemia, and this liberates causing the insulin resistance by doing the Caspase-3 family. Hypothesis Caspase-3 families takes place. Caspase-3, Caspase-6, and Caspase-6-9, and induces periodontal disease. And same vice versa, it brings about diabetes too. That's why where stress upon all the people that we should have good oral hygiene to control the glycemic control. If not, there will be worsened glycemic control will be there. Same again, I said, poor glycemic control will lead to hyperglycemia and oral microbiome, and which will have on the symbiosis or dysbiosis, the upregulation of the and toll-like receptors and 4, and then cell response, and brings about oxidative markers, everything. So I stress on this point is you should have good oral periodontal status to have a good glycemic control. If not, there will be worsened glycemic control. The insulin will become resistant because of the Caspase-3 and Caspase-6 apoptosis takes place. All these things plays a key role in the maintenance. Coming to the cardiovascular disease, they share the risk factors: endothelial dysfunction, addition of the platelets and the leukocytes, monocytes, and there will be formation of the foam cells, and which will act against on the smooth muscle cells proliferation, and finally brings up atheroma formation in the tunica intima. This is what they have noticed between the periodontitis and periodontal disease. However, still research has to happen to get a causal relationship, and same thing that is with the stroke. See, they all share the risk factors of hypertension, diabetes, and history of stroke, and the smoking and coronary disease. And they share the risk factor. That is, I said that periodontal disease plays a key role in all the systemic effects. This is a study that was reported in the literature, association between periodontal disease and stroke. There is evidence that periodontitis is associated with increased risk of the stroke. However, the results of meta-analysis should be interpreted with caution because of the heterogeneity of the studies as well as the difference in periodontitis definition. And say the respiratory disorders. See how the oral mouth here, how it can affect the cardiovascular thing on the lungs, on the bronchus and tracheas, and influence. I'll just show in the slides here. Block bacteria, they shed into saliva. Saliva is aspirated in the lower respiratory tract, lead to infection, and the cytokines from the periodontal side, they enter the diseased tissue periodontium, and they enter the saliva from the GCA, which is aspirated, and will have an infection, and the progression of the infection takes place in the lungs, causing COPD or acute bronchial pneumonia. This is the island of biogeography of theory. How the mainland is in the oral cavity, islands are in the bronchus or in the tracheas, and archipelagos are these ones in biogeography, which has come into the picture of this one. Again, same organisms part about salivary cytokine, as Dr. Vishal Dange said. Now the kits have come regarding that to assess CRP, interleukin-1 beta, as MMP8. The lab-on-chip method is available on the market. Coming to osteoporosis and the rheumatoid arthritis, they share the common risk factors, that is with age, genetics, and the hormones, and change in the smoking and cause calcium and vitamin D, and it brings about the post-menopausal osteoporosis. And coming to periodontal disease and preterm low birth weight children, all these cytokines and LPS and genotoxin, they enter to the bloodstream, and to the third, they cause a rupture of the membrane and brings up adverse pregnancy outcomes in the form of the low birth weight or a pregnancy. This one as a pre-eclampsia and early loss of the pregnancy loss. All because TNF alpha, as I said earlier, it is a suicidal hormone. It causes a rupture of the membranes and brings about the preterm low birth weight. That's why we have to have a good oral hygiene, and we have to instruct the population base, and we have to make emphasis on the gynecologists so they can go back to the patients and confirm what is the importance of the oral health on the adverse pregnancy outcomes. Coming to the rheumatoid arthritis and periodontitis, they have the same pathophysiology and same pathobiology. They say the risk factors, see how it is saying, how the genetic risk factors and the periodontal risk factors, the periodontitis cause the pathogens. They bring about immune dysregulation, citrulation of the products will be there, then chronic inflammation and damage. They share the common risk factors and bring about the rheumatoid arthritis. As Dr. Vishal has said earlier in his presentation, how the periodontal disease can affect Alzheimer's with neurodegenerative disorders. At this point, I want to stress one point. Today, we are working on the P6 medicine and the P5 medicine. This personalized medicines, that is neurodegenerative disorders as well as cancers. We are all working on, they are all brought about the P6 medicine into the picture. Even in the field of pedontology, maybe another 10 to 15 years, we'll also have the personalized medicine called P6 medicine to treat even Alzheimer's. Also, they're thinking about, they're treating Alzheimer's with PRP. They're placing platelet fiber into the nasal cavity and see that they restore the beta amyloid degeneration, all everything. Even with Parkinson's, see how the lipopolysaccharide entering and bringing about destruction of this one. Coming to the final part is about the stress. Periodontal diseases, it has got many, about 85 diseases have been linked. Again with the same LPS, everything, all the induces and bringing about the susceptibility to the periodontal disease, and in turn they bring about the stress. Obesity, as we know that there are adipokines, they have come into picture, adiponectin, visfatin, and so forth. All this obesity will have import glucose tolerance. In turn, it has a type 2 diabetes, weight loss, and atherosclerosis, and it has got an impact on the cardiovascular diseases. All these things through, and it may bring up a periodontal disease. And through periodontal disease, the release of cytokines, TNF-alpha thing, and they again enter the bloodstream and bring up atherosclerosis and type 2 diabetes. As is Dr. Vishal said earlier presentation, oral cavity have systemic disorders, and systemic disorders can have on the impact on the oral cavity. Both have the bidirectional relationship. See, to conclude my presentation today, mouth is a reflection of the systemic health. However, we should have a good quality life. To have a good quality life, we should have a good oral hygiene, and we should have a good oral health, and we are adverse impact on systemic health can be reduced. At this juncture, I'd like to thank my fellow coordinator, Koel Debana, who assisted me for preparing for presentation. Thank you for your attention. I invite the questions.
Thank you very much, Dr. Pradeep. It is not easy to condense such a vast topic in such a short period of time. And as you rightly said, oral health related quality of life is a new paradigm shift. The main problem today is that despite all this evidence, the medical, you are able to hear? Yeah. The medical fraternity have still yet to accept all these whatever that we have put forward. In fact, I was very disappointed. In 2017, World Health Organization brought a new concept. It was called as born too soon. This born too soon was all about preterm low birth weight babies. And, it's a 40-page booklet. You can easily download it from Google. There is not a single word on periodontal disease or oral health in this. All other things are discussed, alcohol, smoking, infections, nutrition, everything have been discussed. Not a single word on periodontal disease.
Periodontitis.
Exactly. So I think we have to convince more and more. We have to bring out more evidence, and then only. Even today when I open the latest edition of, say, Davidson's medicine book, in the chapter on cardiovascular diseases, there is no mention on the importance of oral health. That is really sad. I don't know how much more evidence they want, but we shall keep trying, and I'm sure you will be doing some more research on this. You will bring more things into light. Thank you very much.
Sir, recently we have done a studies, ISP, Indian Society of Odontology and RRDI, diabetic researcher from India. We brought a conference report on this, and we have published in Indian Society of Odontology, joint between the diabetologist and odontologist recently, sir. Even in 2000 science, Journal of Odontology, American Cardiologist and American Association. They have brought out the mechanistic link between inflammation of periodontal diseases towards the atherosclerotic performance. So that will take some time because researchers are working out on this. One explosion of the research is happening, and we get a concrete evidence on this. Systematic reviews or a meta-analysis. Then I think it will take another couple of years down the line.
So the thing is, 2009 itself.
Yeah.
No less a magazine than Times carried a front page cover picture, floss or perish, 2009. I thought by this time we would have had some solid things. But anyway, as you said, it will take some more time. I always give this example. After about 7,000 papers published, 7,000 papers published. In 1961, the Surgeon General of United States declared smoking as a risk factor for lung disease and cancer. Okay, it took that much time. So perhaps we need more time. Anyway, it was a very nice presentation. Thank you, Pradeep, once again.
Thank you, sir. Thank you for giving us this opportunity. Thank you once again.
You're welcome. Our next speaker is Dr. Sahana. She is a professor of oral pathology in Government Dental College, Bangalore. She did her BDS from KVG Dental College, and then pursued her MDS in oral pathology from A.B. Shetty Memorial Dental Sciences. She obtained PhD from Rajiv Gandhi University, and her interest is stem cells and squamous cell carcinoma. I invite Dr. Sayana to give a presentation.
Thank you so much, sir. By paying my respect to Dr. S. Ramachandra Centenary celebration. So today my topic is committee for giving me this opportunity in the great platform. Now, before starting, I would like to just answer a few of the questions why and how the pathology will help in the combined diagnosis. First is, why should the clinically benign appearing lesions be evaluated histopathologically? So usually in our clinics, and histopathological evaluation, and if we just give the treatment, we might not be doing justice to the patient. I will just give one example for that. Here is a case which showed white patch which had come to our college itself, and it looked very much like a tobacco pouch keratosis. We just took the biopsy of that and this was not a benign lesion, but it had an alarming infiltration. It had a worst pattern of infiltration. The crazy very deep tissue. All cells were very pleomorphic. They had a lot of mitotic figures and abnormal mitosis were there. So my only answer is, though it looks benign clinically, we are supposed to subject all these lesions to histopathologic evaluation and do the proper treatment. Now, my second question is, like normally people ask, should the clinically and radiographically malignant appearing tumors be subjected for histopathological evaluation? The answer is yes. Now I will show you one of the case just for an example. Now here is a case which a young boy with a lot of swelling, which was very fast growing. He had a lot of pain, and radiographically also he had a lot of bone loss, and it was in the verge of perforation. But if we had thought, okay, this is a malignant lesion and given a common malignant treatment, then again we will not do justice. So the histopathologic evaluation is very important. Here this case we saw under the microscope, though clinically looked very aggressive, histopathologically it did not look like that. It was just an aggressive ossifying fibroma. So you can understand that we are not supposed to just jump to conclusion. The next is, yes, clinically it is malignant, radiographically it is malignant, and also histopathologically also it is malignant. So the question now is, should we again subject it to further molecular analysis? Answer is again yes. Now an example for that is a child case with a massive swelling of short duration. He had pain. Radiographically also there was a lot of massive destruction, perforation, and histopathologically also it showed malignant features. Now why I'm telling whether we should do further investigation is, now if you see here, all the cells are looking alike. They all are a kind of round cell, small round blue cells. But like what we are seeing here, the Chinese or Japanese people look alike, but we don't know who their parents are. The similar way, here the round cells are there. We don't know what is their parent cell. Why I'm telling this is, their parent cell can be a neural tissue, it can be a melanocyte, it can be a hematopoietic cell, so it can be anything. So the treatment for each tissue will vary. The chemotherapy, what you give, will vary depending upon the type of the tissue. That is the reason we have to further subject such a similar appearing tissue or the cell to the further biomarkers. That is, you can do IHC, rule out whether it is a neural tissue, muscle tissue, or hematopoietic tissue. So we did a panel of such analysis, and we finally came to conclusion that it is a B-cell lymphoma. So my point is, the IHC is very important whenever such round cells or spindle cell tumors are diagnosed. Next is, what is the role of pathologist in the surgical room? So you might be wondering what a pathologist is doing in a surgical room. Now, when a surgeon is excising a surgical tissue or a malignancy, he is supposed to make sure that the margins are clear of malignant infiltration. So if we subject that to the the biopsy, if we send it to the histopathological evaluation, normally it will take 4 to 5 days. But thanks to the frozen section or the cryostat, immediately the pathologist can freeze the tissue, and within 20 minutes using cryostat, it can give a diagnosis. So that then it can say that the margins are clear or not. So this way it can help the surgeon in the surgical room. Next is, what is the role of pathologist in staging? As you all know, earlier we had TNM staging. There was no role for the pathologist. But according to the recent AJCC TNM classification, which is 8th edition, they have incorporated pathological evaluation called as depth of invasion. If you're seeing this picture here, there is a where we can see the basement membrane of the epithelium. And adjacent to that, there is a tumor. So here we are supposed to take this basement membrane as an imaginary line and evaluate the depth of the lesion until where you can see the infiltration. So there we are taking the depth in millimeter, and we are supposed to report it telling that whether it is 5 mm or above 5 mm or above 10 mm. So if the infiltration, if the imaginary line from drawn from the basement membrane is 5 mm, then your T staging will be 1. If it is between 5 to 10 mm, T staging will be 2. Or if it is beyond 10 mm, then the T staging will be 3. So this is the newer addition for the TNM classification. But here, one request to all the surgeons when they do the surgery or when they take the biopsy for such diagnosis or for staging is that they are supposed to give this particular adjacent tissue with the epithelium. If they do not give the epithelial tissue, then the pathologist will end up in giving a wrong depth of the lesion, which will again affect the staging and ultimately it will affect the treatment. Now, these were the questions which is commonly asked, so I tried to give a brief answer to that. Apart from that, in this short presentation, I would like to tell few points about the advancement made in the pathology. Nowadays, we have a lot of understanding on this molecular tissue and the oncology. We have a lot of molecular depth. So one, I would like to explain about it. Now, as earlier pathologists, we used to be under the microscope and we used to give the report depending upon the cells microscope. Poorly differentiated. It is not so. We have gone so deep into the molecular analysis that we can take one single cell, and within that single cell, you can tell which gene is mutated. Is that gene having an the addition, or is there any deletion? Is there any translocation or any chromosomal abnormality? We can find out everything. So now, because of that molecular advancement, we have come to a stage where we can do the medicine, people can do the targeted therapy. We can help them in that way. So earlier, if you can see this picture, now here it is this is a tumor. The tumor has 3 types of cells here. One is the stem cell, there is amplifying cell, and there is a mature cell. Earlier, before we had this knowledge about all molecular analysis, they used to give chemotherapy, and the chemotherapy only used to affect the amplifying cell and also the mature cell, whereas these stem cells were very much chemo resistant. So when the treatment used to end, the swelling used to reduce, but the stem cell will never die. So these stem cells used to remain in the place which could happen after certain time, few months or few years, this stem cell would aggressively proliferate and lead to a very massive tumor which could not be treated, and the life of the patient would be compromised. But nowadays, because of this advent of the newer technologies and the advancement in the molecular diagnosis, we can make out what is the defect in this particular stem cell. We know where the mutation is. So the pharmaceutical companies are coming up with the specific drugs for that specific mutation, and they can treat only that specific stem cells. So we are not, in fact, ill-treating the adjacent stem cells. As you all know, stem cells are required for rejuvenation. So we are not at all touching the adjacent normal cells, but we are touching only the mutated stem cells. This way, the targeted therapy has become a beauty now. Apart from that, the more advanced what we are seeing nowadays is with the liquid biopsy and also salivomics. The liquid biopsy is one such thing where we are using either saliva or the blood to see the circulating tumor cells or tumor DNA or any antigen related to the tumor. Not only tumor, but we are also seeing any antibodies or any other foreign particles you can see through saliva or even through the blood. The main advantage of liquid biopsy over the standard biopsy is that initially we can do the standard biopsy to diagnose it, but afterwards when you're giving the treatment, you want to analyze whether what treatment you're giving is effective or not, whether you want to reduce the dosage after certain time. That way you can monitor whether your treatment is happening or not by taking multiple samples of this blood or the saliva in the certain interval, and you can monitor the treatment. You can personalize the treatment as Pradeep sir told. So now this is the last slide. As I've been given only 10 to 12 minutes, I am speeding up with my presentation. Now, because in this COVID era, there are a lot of research going on the saliva-based test for diagnosis of COVID-19. As we all know, this coronavirus has an attraction to ACE receptors. This receptor especially is present in the salivary duct. So in this recent research, they are thinking that this is one of the area where the viral load can be seen. So there can be shedding of this virus and the viral particle into the saliva. So if you just take some 4 or 5 drops of the saliva and put into the tubes which are already having certain primers, you can, with the colorimetric analysis, you can diagnose whether the salivary this thing is positive for the COVID. So there are a lot of other research going on the salivomics. And now with this fast presentation, I would like to conclude by saying that if you focus a lot on good clinical history, adequate biopsy, and perceptive pathological interpretation, we will plan properly justice for the patient. And thank you for giving me this opportunity. And I thank my colleague Abhishekta for helping me with the presentation.
Thank you, Dr. Sahana. You have covered almost everything in a very succinct, precise way. You know, one of my all-time favorite novels, which I have read 3 times, is The Final Diagnosis by Arthur Haley. You know, there are...
Screen. Hello, sir. Sir, I can't hear you. All kept in mute. Yes. sir's also is muted.
Students today.
Sir, I couldn't hear.
I mean, I'm very sad that oral pathology has fallen out of favor for doing MDS
Yes, sir.
today. I think you showed so much scope for oral pathology.
Right, sir.
I feel of you teachers should catch the attention of the students that, it has got much more than simply examining a few slides. And one thing I told one of my students 2 years ago, she was telling me, sir, I'm getting a all India seat in oral pathology. What should I do? I said, you should straight away join, because as an oral pathologist, you will be accepted anywhere. But if you are a clinical dentist, it is a very hard climb. If you go to, say, US or UK, you have to pass all those board exams, statutory examinations, everything. Whereas as an oral pathologist, you will straight away get a chance either in research or in any lab or any institution.
Right, sir.
And, in fact, I started my teaching career. I began teaching oral pathology, and I could identify many slides, if not by the content, at least by the scratch. Yeah. Very good, Dr. Sahana. Thank you very much.
Thank you so much, sir, for giving me this opportunity. Thank you, sir.
Our last speaker for today is Dr. ShivaKumar, speaking on a fascinating subject, forensic odontology. Dr. ShivaKumar obtained his BDS from Vaidehi Institute of Dental Sciences and MDS in Conservative Dentistry from COTS, Davangere. He is an associate professor in the Department of Forensic Odontology. Forensic odontology was a subject taught to us in preventive and social dentistry, or the community dentistry as we call it today then. It was a very simple topic at that time, dealing with a few things, but now it has grown into such a specialty. In fact, 4 years ago, I had one MDS student who was rather weak. So he wanted a topic on dissertation. I just told him, why don't you compare periodontal status with fingerprints? See if there is any article available. And to my surprise, he brought 3-4 articles wherein fingerprints were correlated with periodontitis, that too, especially the aggressive type of periodontitis. I mean, just as a matter of fact, I'm telling this, but forensic odontology is really a fascinating subject. I invite Dr. ShivaKumar to share his knowledge with us.
Thank you, sir. Thank you, sir. So firstly, I would like to thank Dr. Nagesh, sir, and Dr. Manjunath Puranik, sir, for giving me this opportunity to be a part of Dr. S. Ramachandra's birth centenary celebration, sir. I'll be sharing my screen now. So is my slide visible, sir?
No, your screen is visible, but your presentation is not visible. Can you share your entire screen?
So now, sir?
Go to the PowerPoint.
Can you open your presentation?
So, now, sir?
Screen is visible, but go to the PowerPoint, Shiva.
Can you share your entire screen, sir?
So I've shared it.
Maybe you selected application window.
Yes, sir. I have selected applications, sir.
And did you select the PowerPoint in that?
Yes, I did.
But it's not visible. Please share the entire screen then.
Yeah, I'll try again.
Not the application window, the entire screen. Select the entire screen this time.
This side, sir. So how about now?
No, we still can't see your presentation. Did you select the entire screen, or the
yes, I did.
Or is it the application window?
Share your screen.
Yes. Your entire screen. Then your entire screen, and then share. Don't go to application window.
Okay, your entire screen.
Yes. Yes, now you can open your presentation.
It's fine now, sir?
Yes, open it. Yes.
Yeah.
Thank you so much. A very good afternoon to everybody. I'm here to give a talk on forensic human identification. Teeth are harder than any other tissues in the body and can withstand very high level of thermal, chemical, and physical insults. Therefore, teeth and dentition as a whole is considered as an important source of identification in the living and dead. On the 4th of May 1897 in Paris, an ether oxygen film projector ignited a rapidly destructive fire in a charity bazaar, killing 126 people. 96 victims of the tragic accident were identified visually or by their personal property like jewelry. Almost 30 bodies remain unidentified the next morning, and accurate identification of their remains seemed highly improbable. Then the Paraguayan consulate proposed that the dentists of the victims may be able to play a key role in uncovering the identities of their former patients. With the help of Dr. Charles Gordon, Dr. Isaac Davenport, and Professor Ducornet, 25 of the 30 bodies were promptly identified. Oscar Romero, a Cuban dentist who is hailed as the father of forensic odontology, reported the work done by the dentist and the outcome in his book L'Art Dentaire in Medicine Légale. This was the first milestone in forensic odontology. In simple words, forensic odontology can be defined as the branch of dentistry which deals with law or applications of dental sciences to the branch of law. It involves proper handling, examination, evaluation, and presentation of dental evidences such as teeth, jaws, and oral soft tissues for forensic examination and legal proceedings. Why identification is so important? Identification is required for legal issues and for humanitarian reasons. It may help in settlement of property and insurance-related disputes. It facilitates remarriage of surviving spouse And finally, to facilitate cremation or burial of the deceased according to the appropriate religious and cultural customs. Why teeth is so important for identification? Visual identification fails in case of charred, decomposed, and skeletonized body. Teeth survives post-mortem insults because they are the strongest structures in the body due to their calcified nature. Teeth are again excellent source of DNA. They can provide DNA samples for identification of an individual. There are two forms of dental identification. Firstly, comparative dental identification, also called as post-mortem dental comparative identification. And then second, reconstructive identification, also called as dental profiling. Coming to comparative dental identification, it's basically the identification of the deceased by examining the teeth. It involves personal identification and disaster victim identification. The process of identification. Normally, the circumstances surrounding the death of an individual gives adequate information of possible identity of the deceased. For example, in car, bus accidents, and airplane crashes, visual facial recognition may fail as faces may be altered. However, it is possible to identify the driver or pilot and the passenger based on their various travel records and documents of the victims. Using this, the family or the next of kin of the victims are traced, along with the treating dentist of the victim. The patient's dental charts, casts, photographs, radiographs, and other dental records can be used to conclusively confirm the identity of the disease by matching the postmortem records with antemortem records. The dentist therefore plays a crucial role as the custodian of dental records of all the patients. And it is important for dentists to maintain accurate, updated, and complete dental records of their patients. Postmortem records are commonly noted on in pink-colored modified interpole postmortem odontogram. And antemortem records are noted in yellow-colored modified interpole antemortem odontograms. The key factors to be considered during the comparison of records are the pattern of dentition, size and shape of teeth, diastema, cracks, alignment, missing or supernumerary teeth, presence of stains, and any dental alterations like dental filling, crowns, bridges, dentures, and implants must be noted. Following this, the postmortem and antemortem records are compared manually or by using computer software programs such as Identify, Odontoid, Computer-Assisted Postmortem Identification, International Dental Identification System, and PLAS Data DVI System International. Coming to identification from dental DNA, there are two types of dental DNA. Firstly, genomic or nuclear DNA, and then we have mitochondrial DNA. Genomic or dental DNA is found in the nucleus of each cell and represent the DNA source of most forensic applications. DNA is also present in mitochondria of cells. Thousands of mitochondria are present in single cell. Each of these mitochondria may contain several mitochondrial DNA particles. Cell contains only one copy of nuclear DNA, but 1,000 copies of mitochondrial DNA. Hence, mitochondrial DNA can be obtained when the nuclear DNA type cannot be. In nuclear DNA, one half is from mother and one half from the father, whereas in mitochondrial DNA are inherited in a strictly mother-to-child manner. There is no paternal contribution. Thus, an identical mitochondrial DNA pattern is observed among siblings and many maternal relatives. Coming to reconstructive identification. Here we try to ascertain the possible identity of the individual. It involves determination of race or population, sex determination in skeletal remains, and dental age estimation. We know humans are diverse species as a result of genetic influence and environmental factors, such as climatic and geographical locations. Certain indigenous distinguishing factors can be identified in dental morphology as well, making it possible to identify an individual ethnic origin based on dentitions. Presence of features like shoveling of incisors, cusp of carabuli on maxillary molars, and winging, which is found more commonly in certain specific population, can play an important role in eliciting of ethnic origin. Sex determination. We have been using features of skull and mandible of different differentiation between male and female. However, sexual dimorphism can be observed in individual by using the dentition. Male teeth are anatomically large than female teeth, and sex determination can be done by measuring mesiodistal and buccolingual dimensions of the teeth. Sex determination by DNA analysis. DNA analysis for sex determination gives highly accurate results. The amyl or amylogenin is a major matrix protein found in human enamel. It has a different signature in male and female enamel. The amyl gene coding is located on the X and Y chromosomes in humans. The females have 2 identical amyl genes and 2 non-identical genes in males. Authors have obtained 100% success in determining sex of an individual. Next, coming to age estimation. We all know that Ajmal Kasab, who was a lone surviving Pakistani terrorist captured during 26/11 terror attack, had pleaded to that he was a minor, and his lawyer asked for the case to be transferred to Juvenile Justice Board instead. Ajmal Kasab's ossification test and dental test was done to determine his age. Later, the court turned down the plea. Age estimation can be done on dead and living subjects. The age of younger individuals can be estimated more accurately. However, in older individuals, age-related alterations make the process more difficult or less accurate. Dental age estimation can be done on the skeletal remains or on the postmortem remains. Measurement of dentinal translucency is a simple method which gives fairly accurate results. In the living, there are various methods of age estimation, of which the most commonly used methods are Shaw's method, Demijohn's method, pulp to tooth ratio method, and open apex method. Coming to bite mark. As we know, the horrifying Nirbhaya case involved rape and fatal assault. I would like to mention that the bite marks found on the body of the victim were compared with the dental models of the suspects. This analysis conclusively proved that the bite marks were caused by accused Ram Singh and Akshay. Basically, the arrangement of teeth in every individual is unique. We can make use of this technique, features of a person's dentition, to compare with the bite mark in sexual assault and child abuse cases, thus helping provide substantial evidence in criminal case proceedings. Bite mark identification is based on individuality of the dentition, which is used to match a bite to a suspect. Matching is done by tooth-to-tooth, arch-to-arch comparison using parameters of size, shape, and alignment of the teeth. Lastly, I would like to say a few words about rugoscopy and cheloscopy. Rugoscopy. This method employs identification of individual by examining the palatal rugae patterns. This is useful in identifying an edentulous person. Basically, it involves examining the palatal rugae pattern on the diseased maxilla to old dentures or dental casts. Cheloscopy or lip prints are unique and do not change during the life of a person. This can be obtained at crime scenes from clothing, glasses, cigarettes, windows, and doors. Lip prints can be made visible by using aluminum powder and magnetic powder, thus helping in criminal cases. With this, I would like to conclude by saying forensic odontology is much of a science than art, which requires or demands patience, time to study, research, and to plan. Dental identification technique is quite reliable and economic. Hence, more research and study by the dental personnel is required.
Thank you, Shiva. It was an excellent presentation. You have given us all the basic aspects about forensic odontology. Just as a sideline, one question I have for you is, now I am 65. My fingerprints are fading. It's a big problem for me when I go for a identification, either for Aadhaar or even to mark my attendance in my school.
Yes.
Is there any, newer methods or more sensitive methods to identify the fingerprints that are available?
So yes, sir. Now also with the fingerprint analysis, the analysis can be done, sir. Basically, the age will not matter much.
Okay.
Yes, sir.
Because every time when I am asked to show the finger, even when I landed in Germany, the airport, it simply refused to acknowledge my fingerprint. You know,
Yes, sir.
I was just asking. Yes, what you said, Dr. Shiva, is very pertinent. But one important thing I would want to emphasize on all my colleagues, it is the maintenance of appropriate dental records of every patient
True,
whom
sir.
they see. See, unless the previous records are there, it's very difficult to to compare anything in such things. So the value of a dental surgeon increases if proper records are maintained. So that brings us to the end of today's program. All the speakers spoke very well. There was a lot of good points and things that we learned in this program. I want to thank GDCRI for giving me this opportunity to moderate this whole webinar series. Again, my humble pranams to Dr. S. Ramachandra, the doyen of dentistry in Karnataka. And again, thanks a lot. No amount of thanks is enough to Dr. Leena for giving us this platform to showcase our webinars. And, we did our prologue some time ago. And, it's really nice. Thanks, Dr. Girish Reddy and Gireddy and Dr. Manjunath. You have been very helpful. And I hope we'll have more such programs in the future. I can see Dr. Girish Rao still raptly listening to this. It was wonderful to be associated. Thank you very much.
So thank you so much, sir, for your wonderful moderation. It is with your experience and expertise you are able to give us a lot of information and add value to our webinars. So I take this opportunity to thank all the speakers who are here with us to share their expertise. Tomorrow we have 5 webinars lined up with a variety of topics. To start with, we would be having a talk by Dr. S.S. Hiramat sir, that is on oral health policy, a way forward. Then we have by Dr. Reena Kumar, sleep medicine, role of orthodontist. Then minimal intervention and tissue preservation by Dr. Kiran Kumar N. Current possibilities in rehabilitation, Dr. Ananda Krishna. And finally, dental home, akin medical home by Dr. Nagaratna. So we would be waiting for all the participants tomorrow at 11 a.m. Kindly join and let us make the effort successful. I thank once again the organizers, my teacher, Dr. Nagesh sir, Dr. Faizuddin sir, who have been instrumental in planning, designing this webinar, my director, Dr. Girish sir, and all who are involved in this particular effort. Thanks to one and all. We'll meet again tomorrow morning at 11 a.m. Thank you once again. Have a good day. Thank you so much.
Thank you very much.